Assalamu alaikum. Thank you very much for joining today. We're going to start the program with recitation of Quran.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. أقم الصلاة لدلوك الشمس إلى غسق الليل وقرآن الفجر إن قرآن الفجر كان مشهودا ومن الليل فتهجد به نافلة لك عسى أن يبعثك ربك مقاما محمودا وقل رب أدخلني مدخل صدق وأخرجني مخرج صدق واجعل لي من لدنك سلطانا نصيرا وقل جاء الحق وزهق الباطل إن الباطل كان زهوقا وننزل من القرآن ما هو شفاء ورحمة للمؤمنين ولا يزيد الظالمين إلا خسارا وإذا أنعمنا على الإنسان أعرض ونأى بجانبه وإذا مسه الشر كان يئوسا قل كل يعمل على شاكلته فربكم أعلم بمن هو أهدى سبيلا ويسألونك عن الروح قل الروح من أمر ربي وما أوتيتم من العلم إلا قليلا ولئن شئنا لنذهبن بالذي أوحينا إليك ثم لا تجد لك به علينا وكيلا. صدق الله العلي العظيم.
Thank you very much for that beautiful recitation. We're very fortunate today to have a regular of ours, Dr. Umar Ebrahimsa, speaking to us on COVID, from crisis to normality. Dr. Umar is well known within Muslim circles, having spoken at a number of different mosques, as well as here on a number of different occasions. He is a specialist in infectious diseases and general medicine, and is someone who we're very fortunate to have here today. So without further ado, let's welcome Salat ala Muhammad wa ala Muhammad.
Assalamu alaikum wa salatu wassalamu ala rasulillahi wa ala alihi wa sahbihi wa man wala. Thank you very much, Mikdad, for inviting me along. And I apologize, this is going to be primarily a very short talk and an opportunity then for questions and answers to follow. And let me just see if I can share my screen.
Whilst it's checking, just a reminder, when you do ask your questions, please feel free to ask them directly on YouTube, or you can, if you just send a message, we can get you to ask live as well. You can ask on YouTube, on Facebook, on WhatsApp, or any other social media mechanism, and we will make sure it gets asked. Omar, please.
Thank you. Mikdad, can you see my screen there?
I can't, so if you press...
Can't. Okay. Let me just escape from this. Come back. Try sharing this again. Sorry. Apologies for this. I think in the interest of time, I'll leave that be. Yes, let me email it to you then, Mikdad. Apologies. Let's get this through. So in essence, we're now, or rather, I thought it would be useful to recollect where we were in March of last year. And I think the first time that I started speaking about coronavirus and COVID was in the context of an expanding outbreak within Iran and Italy. So just before the tides hit the UK. And at that point in time, we felt that we were probably well prepared, We had a national healthcare system that covered everyone within the country. We had the means of transferring resource from one area to another. And we could cope perhaps with stresses that the system was put under. And we felt that we had multiple planning exercises, and increasingly it looks like planning for a pandemic, whether it was due to Ebola or due to a coronavirus or due to flu, had been ongoing since the early years of this millennium. But for one reason or another, those lessons were neither learnt nor implemented. And when these tides did hit our shore, they came crashing through every single institution that we had, and displayed often the complacency and the weakness that then led to 160,000 deaths within the UK to date. So it's not been an easy year for anyone. But at the same time, I think taking a step back, it has been remarkable that an advanced, highly integrated, technologically sophisticated civilization has been brought to its heels by something that spreads in the air, unseen, untouched, almost like dust that falls to the earth. And in that context, there have been a number of lessons that have come out of this. Lessons on how we understand disease and its spread, lessons on the implications for this, for the way we live and the way we treat our ill, and lessons on the limitations of technology within the context of a modern liberal society and a free market economy. And what I'd like to draw you back to is the virus itself. And I'm sure all of you would have seen many different representations of it. But let me draw you a picture of this sphere studded with almost rivets protruding from its surface, through which it locks onto cells within your lungs and then gains entry into the body. And within it, the genetic material that this virus so deeply guards. Thank you, Mikdad. So if you advance to the next slide. No, one back, please. And this is a representation of the virus. This prickly little sphere that sits there suspended in midair, hanging with each droplet that we breathe or speak. If you go back, we breathe or speak, and capable of causing such great devastation. And it's humbling that this should be the case, and fascinating when you look at it from a medical perspective in terms of what this virus can do. And those thorns that you see protruding from its surface, that it gains entry into the human body with, are the focus of both a great deal of human effort for the last 18 months, but also the focus of how our body attempts to contain and control this. And it is this, the spike protein, if you like, that seems to be the trigger for our immune response, with the antibodies that anyone produces after infection primarily focusing on this. So this is the calling card of the virus. This is the way that it makes itself known, And this is the way that it causes damage, and quite reasonably, this is the way the body knows it. And that begs the question then of what a virus is. This barely living entity that needs to enter into another living being, that needs to hijack the machinery of life, if you like, in order for itself to survive and proliferate. And so to be able to proliferate, this virus needs to enter into someone else. It then needs to be able to hijack your own biology in order to produce more copies of itself. And then it needs to be able to break out and go on and continue the cycle. So there are 3 key steps there: entry, replication, and escape. And at each of these points, it's vulnerable to detection. At each of these points, there are various mechanisms that we use to control it. So, for instance, when the virus initially presents itself, the presence of this spike protein alerts the immune system for us to be able then to contain it. And when it replicates within the cell, the production of that spike protein is then the thing that awakens the immune system to the presence of the virus and enables it actually to kill off the cells in which this virus is present. But what does that mean for the virus? If you put yourself in the place of the virus for a moment, it needs to replicate. It needs to enter into a host and then go on to another host. And if its calling card is a thing that it is recognized by, then the most sensible thing, the most reasonable thing, and of course this is a thought experiment, this is not viruses don't think, but we'll come back to this in a moment. The most reasonable thing is for that spike protein to change. And what happens is a virus, like any other living being, attempts to replicate itself by reproducing its genetic material. Now, some viruses, like the flu virus or like HIV, deliberately have a faulty means of replicating themselves. So if you imagine that the genetic material is a pack of cards and they keep producing another pack of cards, but instead of having a reliable copy, the copy always has mistakes in it, and huge numbers of mistakes in the case of the HIV virus. And viruses also have a means of proofreading what they've copied. But the proofreader that HIV has is incredibly faulty, so it lets these mistakes go through. So these mistakes, these mutations, then go through. In the case of coronavirus, its proofreader is pretty accurate, so it doesn't tend to cause that many errors. But there will always be an error, say about a mutation every month or so in a virus when it's allowed to survive. And what happens then is that if this mutation enables the virus in one way or another to infect others more readily, so transmit, or to be able to replicate more rapidly or more prolifically, then what will happen is that there will be more viruses around as a result of that. And this is what happens with the new variants that we see occurring, and I'll come back to that later on. That because of this, these mutations being favored, you end up with new spike proteins or new shapes to those spike proteins, allowing the virus to become more transmissible and allowing the virus to become more, not necessarily more virulent, but more able to reproduce itself. And this seems to happen particularly in environments where you have huge amounts of infection going on. So it's interesting that we've noticed variants in Brazil, in South Africa, in the UK, and in India. There are variants elsewhere as well, but these are the 4 main variants that have been identified that have spread rapidly through populations. And these are all countries where there have been higher than or more severe infections from a population perspective. There's been more extensive infection in the population. So more people are infected. And that will include people who may not have an immune system that functions very well, they're very elderly, those on medication that suppresses their immune system, or those who have conditions like diabetes, like steroid use, like HIV, which would compromise their immune system. And in that kind of context, the virus can linger perhaps in the body of the individual. And it's repeatedly exposed to these antibodies and cells that come and try and mop it up, but don't quite manage. And it just shifts slightly away from the surveillance mechanism of the body's immune system until eventually it's shifted sufficiently to have produced a variant that can spread rapidly. And that's what we think may have happened in the context of the Kent variant. The other thing these viruses can do is recombine. They can share their genetic material. There's some evidence that that happens. Why am I emphasizing this? Partly because I think the development of these variants is part of the normality that we're going to have to face. And that, I'll come back to that in a moment. Mikdad, can I have the next slide? So where do we stand today? This is a plot, if you like, of the number of cases that have occurred in the UK since March the 1st of last year. So it covers primarily the main waves that we had to the tail end of last year, the second at the initial hump, and the third wave during the winter and over into this year. And from the second wave, this is reasonably reliable data in the sense that we were able to test quite widely, and we have now begun carefully assessing or characterizing the viruses that we're finding spreading in the population. But if you look at this, what you'd note is that at the peak in late January, February of this year, 50 to 60,000 people developed infections every day. And that's almost tenfold more than today, 5,000. But in between then and now, there was a point when we had about 2,000 infections a day in the UK. And for some reason now we've had a doubling in that still relatively low level, but a doubling, which is causing a great deal of concern. But what is interesting about this, Mikdad, could you put the next slide up? This is a plot of the deaths that we've had on a daily basis from April of last year until the end of May. So it covers the tail end of the first wave and the beginnings of the second wave and the third wave. And what you notice here, so it covers roughly the same timeline as the previous plot, is that if you look at that extreme right end, despite an increase in the number of cases over the last 2 to 4 weeks, there doesn't appear to be, sorry, this is not the deaths, this is the hospitalizations. There doesn't appear to be an increase in the number of people coming to hospital. So although we're seeing more illness in the community, not as many people are becoming as unwell as they were earlier on this year. And that's interesting, where you would have expected a dramatic increase in the number of people who are ill in the community to then feed in, at least a week or two later, into a significant rise in those coming to hospital. We're not seeing this. And that's a reasonable question to ask in terms of why is that the case? And if we look at the next slide, which details the deaths from COVID since the end of March last year, what you find again is that we're still at a low level of deaths compared to the 1,200 deaths a day that were occurring at the middle to end of February. But this is reflective, if you think about it in terms of infections, this reflects the, if you like, this is a picture. Each death is a picture of what happens in terms of infections 4 to 6 weeks beforehand. So what's happening on the ground now will only really reveal itself in about 4 to 6 weeks' time, and that's why there is the concern. We have an increasing number of infections, but yes, not as many hospital admissions. And there is uncertainty about whether that is going to remain the case or whether we will see an increase in hospital admissions. Now, there is some optimism in thinking that we will not see an increase in hospital admissions. And that is primarily because of the extensive vaccination drive that has happened, with over 3/4 of the UK population now having had their first vaccine, and over half, I think 54% of the population, now having had the second vaccine, the second dose of the vaccine, so being fully vaccinated. Which might explain the delinking between the number of cases occurring in the community and the number of people going into hospital. Can I have the next slide, Mikdad? So, coming back to that story earlier on about this virus that is desperately trying to find a way to be able to proliferate and persist, where the best way of proliferating or persisting seems to be altering its spike protein so that it can enter into the human host more effectively and so that it can jump from person to person more easily. You may have heard recently that in an attempt to, shall we say, be more even-handed and to avoid stigmatization, these new variants have been relabeled according to the Greek alphabet. Alpha being the variant that was predominant, the Kent variant predominant over the Christmas period, and Delta here, the variant that was predominant now, the Indian variant. And what's interesting here, if you look at this, this is a document produced by Public Health England, where they're analyzing the variants circulating within the community. And from about 2 weeks ago, every positive test, so everyone, any test that comes back positive for coronavirus, if it is a new test or new within a particular period of time, is then retested to see whether it contains one of 4 variants of concern. So you'll see there are more than 4 variants here. And that's because there are lots of variants. We have variants classified as being under investigation because they're present in the community. Variants of concern because they spread more rapidly or are causing more severe illness. So we will have a better picture of how this pans out over the next few weeks. But with the alpha virus, if you look here, between the beginning of February and the end of May, 138,000, 139,000 people had tested positive with the alpha virus, with the alpha variant. And the majority of people attending A&E, and about, let's say about 6% of them ended up attending accident and emergency, about 8,000 here. And about 2,000 went into hospital. So that's 1.5% required hospital admission. If you look further down that list at the Delta variant, the Indian variant that is of concern, currently the next most significant variant within the ones under investigation, between the end of February and May, and the numbers are much larger now, about 9,500 cases of the Delta variant were identified. But only 1% required hospital admission. So that is significantly less that is significantly less than the 1.5% requiring hospital admission and an overnight stay with the Alpha variant. So it does suggest that there is this separation between people becoming ill in the community and who comes into hospital. Can we carry on to the next slide, please, Victor? And if you look at this further, and you look at, again, this is from the same document, and you look at the vaccination status of those 9,500 individuals who had the Indian variant, then what you find is that the vast majority, 5,000 of them, were unvaccinated. And only 260 had received both of their vaccine doses. So, to my mind, that does show a significant benefit of vaccination, and consequently probably explains that delinking between cases in the community and hospital admissions. Next slide, Victor. Which brings us to the question of whether the vaccines that are currently used in the UK, the Pfizer-BioNTech and AstraZeneca, are effective against these variants. And we have here the old nomenclature. So B1617.2 is the Indian variant, the Delta variant, and the other variant quoted is the Alpha variant, which is otherwise known as the Kent variant. And what you find here, is that both the Pfizer-BioNTech and the AstraZeneca vaccines were effective against this. With Pfizer-BioNTech providing protection against severe illness, and this is a key point, that this is against symptomatic illness rather than asymptomatic illness. So these are people who comparing, if you like, those who are vaccinated and those who are not vaccinated, and whether they develop symptoms of COVID, but not necessarily following them off for asymptomatic infection. And Pfizer-BioNTech has a effectiveness of about 88%, at least 2 weeks after the second dose, in the context of the Indian variant, so the Delta variant, and an effectiveness of about 93% against the Kent variant. Similar protection in this case. AstraZeneca has an effectiveness of about 60% for symptomatic disease against the Indian variant and 66% against the Kent variant. So what's interesting here, of course, although the figures seem to be grossly different, if you match this with another study in Scotland of 2 million people who were fully vaccinated against coronavirus with AstraZeneca, with Pfizer, you find similar levels of protection against the Kent variant, although that doesn't seem to be the case in this smaller study. This may be because the AstraZeneca vaccine was rolled out slightly later, and also because the efficacy of the AstraZeneca vaccine seems to be to improve slightly later after the second dose. Next slide, Mikdad. I think that's, yes. Let's go back to the previous one. If you can just go back to the original slide, the virus picture. So in this context of novel variants presenting themselves repeatedly over a period of time and the uncertainty that is caused, I think what we may end up having to accept is that COVID and coronavirus are part of our normality. That it is impossible for us to think of a world that happened before, but to attempt to live in a world with coronavirus. As we move from an epidemic that has become a pandemic with tremendous global suffering and change, to then moving to a situation where we have continued low levels of infection in a community as coronavirus becomes part of us, in the way that flu became a part of us, probably at least 1,000 years ago. And in the same way that we have annual flu seasons, we are likely to have periods of time in which there is higher levels of transmission of coronavirus. Perhaps behaving similar to flu, with sudden changes to the virus causing rapid transmissibility and more pronounced disease, and the potential for causing a pandemic. But a potential that will be limited by the capacity of our immune system to be able to contain this virus. And that depends upon factors that protect immunity in a community, whether that is the levels of inequality within society, the levels of poverty within society, the levels of discrimination in society, all of which prejudice the well-being of sectors of society and make them more prone to infection and compromise their immune well-being. Or whether it is through the vaccination process that we have in place, where what will determine our ability to protect ourselves against this is the ability of these vaccines to induce an immune response that covers these new variants. And this is another part of the story that has come to the fore. That disease, we've always known this, but it's fascinating looking at it now, that disease is like weaving a tapestry. It's like a man sat at a loom with threads stretched across it, as he then feeds more perpendicular threads to this, and the warp and weft, as they lay upon one another, then become the carpet, where the virus itself and its capacity to cause illness is just one element in this. And this is very well highlighted in coronavirus, where we see our understanding of it is such that we see that initial phase where a virus enters into the body and then causes massive damage to the lungs, massive direct damage to the lungs, is but one element in the story, because it is the body's response, the immune response thereafter, and the overwhelming surge of production of chemicals that destroy, that damage, that undermine the body's own tissue, that actually cause more significant injury. And that immune-mediated illness in the second part is probably the thing that we have better treatment for now than the initial phase. For even as I speak today, we only really have one medicine that reduces the risk of dying from coronavirus, and that is actually only in a select group of people, that is people who need oxygen. And that medicine is dexamethasone, a steroid given in high doses for a limited period of time. And there doesn't appear to be any other treatment that has been trialed that has shown any benefit in protecting people from death from coronavirus. There are other benefits that have been shown, like reducing the risk of requiring intubation or ventilation, or reducing the amount of time you need to stay in hospital. And medicines that affect other elements within your immune system, for instance, blocking the production of an agent called IL-6, interleukin 6, in the case of tocilizumab, or blocking another signaling molecule, JAK2, in the case of an agent called baricitinib, have also shown some promise. But we are faced with the reality that we don't have an effective means of treating people who don't require oxygen within a hospital setting and protecting them from dying. What is interesting, though, is that there is a trial that's been completed in Oxford which shows benefit in using inhaled steroids, a steroid called budesonide that's sometimes used in the context of asthma and prevents people requiring hospital admission. So this is in mild disease. It prevents people requiring hospital admission. And this, rather than hydroxychloroquine, rather than ivermectin, rather than azithromycin, rather than colchicine, rather than a host of other agents, has been shown to at least prevent hospital admission. But that's it. That's about it so far. But having said that, the process of coming to this and the organized international trials covering hundreds of sites, hundreds of different hospitals, all coming together to look at how we can best treat people, has created a collaboration that can be built on into the future. So that, if you like, that shift, that need to move beyond the parochial and the local and to create associations between different countries, between different departments, is another element of this COVID story, and perhaps another element of the normalization that will come out of this. But when I spoke earlier about the need to accept that COVID forms part of our normal framework, the one thing that we may also need to consider is that, at least for the medium term, so looking into next year, maybe the year beyond, the kind of non-pharmacological measures that we take, our distancing, our hand washing, our masking, will probably need to continue until we have more than well over 80% of the population vaccinated and levels of circulating coronavirus are at their minimum. Remember, we said that you're likely to develop new variants in a situation where you have a surge in infections. And that's shown by the last slide I have here. So if you could just point to that, Migdad. There. So this is the result of a study called the Siren study, looking at about 45,000 people in 135 different hospital sites across the UK. And they're people who were enrolled about a year ago in this study and have been followed up, I think, every 2 weeks with a swab, and in whom about 1/3 were already producing antibodies against coronavirus right at the beginning, and where about 95% of this cohort are now fully vaccinated against coronavirus. But it's looking at the development of repeat infections. So this is reinfections. And let me just draw your attention. This is a study of 45,000 people. I'll just draw your attention to the y-axis and the peak of the y-axis, and the fact that at the peak, during the course of the most recent wave of infections, at most, out of 45,000 people, at most, about 75 had developed a reinfection. So reinfection is rare, and this is rare in a population that was seeing this: healthcare workers, seeing people who are ill with coronavirus, going often working in closely packed environments. Most of them actually, I think, using public transport, but I'll come back to that later. So people who are heavily exposed, the vast majority, less than a fraction of 1%, less than a fraction of 0.1% had developed infection. So it's a rare occurrence, but what's interesting is that the occurrence parallels the presence of coronavirus in the community. So the likelihood of someone becoming infected is related to how many people around them are infected. And as a result, it's only when we have sustained low levels of infection that we can perhaps begin to relax somewhat the distancing and the masking that we're currently adopting. So what's my take-home message here? My take-home message is that what we're seeing, the trauma, the drama, the destruction that we've seen, is part of an ancient and ongoing process where agents that we cannot see, that we cannot feel, transfer and transform, become something that used to infect animals and then infect humans, and jump from one group to another. And it's happened before with flu. It's happened before with coronaviruses. And in this case, may mark the entry of this coronavirus into a human population, and then subsequently its normalization as part of our background. But in the process, there is this transformation of society that happens. And to some extent, we see good out of it in terms of the collaboration that occurs, in terms of our understanding of illness, in terms of the need to address the broader determinants of health. And to some extent, we're seeing, and I'm sure other speakers have spoken about this before, the fossilization of differences within society and the dangers of authoritarian rule, particularly in countries which have had high levels of coronavirus: Brazil, the UK, the US, and India. And I think I'll leave it there for now and open the floor to any questions. Thank you very much.
Thank you very much for your talk and for sharing really important questions. There are a lot of questions, so can I ask, as much as it is really possible, to keep the answers short? Some of these will be very quick answers, so hopefully we can start with a quick yes/no type stuff. So let's start with the first one. Is UK testing for ivermectin as a therapeutic and for treatment of long COVID?
There's an ongoing trial that started recruiting in February of this year, looking at ivermectin as a possible treatment. There is currently no evidence for ivermectin being of benefit in either prophylaxis or treatment. So the evidence is out. We're waiting to see what happens.
Thank you. Next one. If you have the vaccination, could you still test positive?
So the vaccine protects against symptomatic illness, and that's very important. It protects the individual from developing severe illness so that they end up not requiring going. So it stops you going to hospital. So you're not sitting there gasping for breath, literally drowning in air. But you can still get the infection. And in fact, you can get it more mildly than you would have otherwise. and so as a result can still transmit, which is why I think these non-pharmacological measures, the distancing, the masking, the hand washing, will still be a practice that we're going to have to adopt until there is sustained and very low level coronavirus in the community.
Is there evidence about vaccination impact on long COVID?
So the vaccines have only been rolled out since December, the middle of December of last year within the UK, and we were one of the first countries that rolled this out. So the impact on long COVID, it prevents you getting severe COVID. I guess the question is whether if you have milder COVID, you're likely to have long COVID. That I'm not aware of any data on that.
Thank you. Do we have any comparison between what has happened and what was expected from the vaccines in terms of death rates? I think this is referring to the fact that there's close to 0% chance of death shown with most vaccines in the numbers that we saw. Are we getting close to that 0% in reality?
So there isn't a 0% chance of death. When we talk about vaccine efficacy, we're looking at how well the vaccines protect you against developing symptomatic disease. So you saw there figures quoted of about 90% in the context of Pfizer and AstraZeneca, at least in the Scottish studies. But that means 10% of people who have vaccines can get symptomatic disease, and a fraction of them will go into hospital, and a fraction of them, unfortunately, will pass away. And this is more likely to happen within a context of overwhelming illness in the community as a whole. But that percentage who develop illness is far, far less because of the efficacy of the vaccine, far, far less than if they weren't to be vaccinated. Does that answer the question? Does it?
Perfect. I think that's fine. Is there any chance that the better performance of hospitalizations is due to the fact that so many older people and those with pre-existing conditions have already died and that care homes are more protected?
So have the susceptible population either been protected or they unfortunately have passed away? So care homes are protected. Care homes are the places which have been most heavily vaccinated. In fact, it's in that cohort that has been vaccinated, the over 80s, that you find the greatest evidence for benefit in terms of the reduction in hospitalization. So I don't think it's because they've died. I think it's because the vaccines are working.
Thank you. What's the latest view on the requirement for booster vaccines?
So boosters, there are two variables that you need to consider. How long will immunity last for? And whether the vaccines will cover the variants that are present within any community. It looks like the vaccines will cover the Indian and the Kent variant. So from that point of view, there's no real need for a booster to deal with them at this point in time. In terms of the durability of immunity, we will have to wait and see. That will only be apparent towards the end of this year, as you see as you're more than 6 or 7 months after full vaccination of a cohort in the population. And so as a result, the coming winter, when we're expecting a surge in coronavirus, will be the key point to determine the issues around durability and also the variants that are there in the community.
Thank you. Blood clots and fertility risk were raised as issues as potential risks of the vaccine. Has the real world impact shown these to be myths?
So blood clots are a significant issue. There is, Mikdad, what's the global Koja population?
150,000 or something?
150,000.
I'm making around them.
Okay, so assume 150,000. So if every Koja in the world were to be vaccinated, you would expect about 1, maybe 2 of those in that population to develop blood clots. So it's a very, very rare occurrence that seems to affect young women in the main. And young women are also the group who tend to develop blood clots in the context of even before COVID. So these are blood clots affecting major veins supplying the brain, the lungs, and the stomach. And it has occurred at a very, very low level, and that's part of the reason why in this population, and that's part of the reason why in the UK an alternative is provided for individuals under the age of 40. So there is an issue there, and it's something that occurs so rarely that it was only identified after several million people were vaccinated. With regards to fertility, there's very good evidence actually of COVID causing problems with fertility. So perhaps protection against COVID would protect fertility in this case. There's no clear evidence at all of vaccination causing impaired fertility.
Thank you for that. What is the situation of Bain disproportionality in impact in the latest phases?
I don't understand that question.
In the earlier phase of in the first wave, there was a significant disproportional impact of COVID-19 on BAME communities. Has that continued in the recent times? We haven't heard as much about it.
As far as I'm aware, that still stands. That still stands. There is some variation between ethnic minority communities or apparent variation within the data, but the general trend of poverty, age, discrimination or marginalization within society as being important factors is still present.
Thank you. In the end, is herd immunity the only answer?
Yes, of course. I mean, that's the whole point of vaccination, so that people, we can reliably and safely enable people to develop antibodies and an immune response to the virus, so that they're protected from it and do not develop severe infection and do not need to go to hospital.
Thank you very much. Rattling through these. The government has talked about postponing the opening up by another month. What is likely to be its rationale?
So the surge in cases that you're seeing, the increased number of the Indian variant, which is now the predominant variant within the UK, particularly within the northwest of England and in London, has caused concern. So there's a higher number of cases in the community. And even if a smaller proportion of them are going to hospital, if there is a surge of infections as a result of a more transmissible virus, and it appears to be anywhere between 50 and 60% more transmissible than the Kent variant, which itself was 50% more transmissible than the original variant that we saw in the UK. So about 3/4 as more transmissible than the original variant from last year. So if that is the case, that despite the fact that there's a smaller proportion going into hospital as a result of this, because there are more people becoming unwell, the total numbers of infection are higher, we may still see an increase in the numbers going into hospital rather than looking at the numbers per head per thousand of population.
Are the previous concerns about the NHS being overwhelmed a potential anymore given the vaccination?
So one hopes that's not going to be the case. And there are two elements in this. Are we better prepared? Do we have better services in the background to be able to support in the context of a surge or stress against the NHS? And I think there is an element of that, but it's very thin. It's very vulnerable. And do we now have a means of reducing the number of people who require hospitalization? So in reducing hospitalizations, places like Vietnam, places like Australia, places like New Zealand, and even China have shown that you can do this without vaccination. That's through effective testing and tracing and the non-pharmacological interventions that we talked about before. And what we're seeing here in the UK, in the Eastern Mediterranean, may also show us a means to if you like, may also show us that vaccination could do the same thing.
Okay. What's your view about vaccination of children?
So it depends upon the age, doesn't it? I think vaccination in this case, I would very carefully consider in any age group. And for children, you are particularly concerned because they are still developing. And the decision to take a vaccine is often not the child, it's often someone else's. Whereas in an adult consents. So consequently, so long as the trial data is present and so long as there has been adequate assessment of that data by independent, well-funded agencies like the European Medicines Agency, like the MHRA, like the FDA, and data is published in the public domain, and there has been appropriate counseling of individuals who have had the vaccine, then I would not have a problem with children having the vaccine.
Does such data exist right now?
So that data is developing. There are ongoing trials on childhood vaccinations from the age of 12 to 15 for both Pfizer and AstraZeneca, and I think the Moderna vaccine as well.
So at the moment, there is no evidence to suggest it's worth taking yet.
So I would need to look into this in more detail because I tend to specialize within adult medicine. And when it comes to children, what I'm aware of is ongoing trial data, or ongoing trials rather, and these will be submitted to the relevant regulatory authorities before approval is sought.
Okay, perfect. The last three questions we've got here are all international relations, related to the international questions. So firstly, is there any value in closing borders if we already have large numbers of people vaccinated? Aren't we going to face these variants sooner or later?
Good question. So I guess let's do a thought experiment here. You have a variant that's present within the UK. That's the Kent variant, let's say, surged through the population. It's devastated the economy. It's closed down the healthcare system. And you are sat as the health minister in Tanzania looking at this data, wondering whether we should prevent people from the UK coming to Tanzania, or at least make sure that they are appropriately quarantined in monitored facilities so that they are no longer, these Britons are no longer a threat to the Tanzanian population. What's the point in doing that? The idea there is that you're living in Tanzania and let's say for argument's sake, you have a low level of infection in the community. If one of these Britons turns up and ends up traveling through your community and transmitting a virus that is more transmissible, that has that is privileged, that has a greater threat to the population than your existing virus, then you're putting your population at risk. And that would be unreasonable. So as the Tanzanian health minister, you'd expect them to stop that transfer of virus from a damaged and dangerous Britain to East Africa. And the other element here, the other scenario is this. If you are in India today and you have something like 1.3 million deaths occurring on your doorstep, some of which can be which are not going to be detected because they're occurring in rural communities, or because health agencies are not documenting them, then you have an overwhelming surge of infections occurring. In that kind of context, where you have this overwhelming surge, you will see within your population multiple variants. And you will see increasing pressure, or the virus will try and develop ways of spreading more effectively. And the fact that you've had a surge suggests you have a form of the virus, a variant, that has been successful at doing that. So in that situation, you become the risk to others. If you, as the Minister of Health for India, are faced with a Briton who's coming from now a relatively a low level of infection in the UK to India, are they likely to have a variant that transmits as well or better than the variant, from the virus point of view, than the variant that's there in India? You're less likely to. And so in that kind of context, it may be reasonable to have a more relaxed perspective on this. So if you wish to maintain low levels of infection, like the Tanzanian health minister, then you would want to stop the Briton coming in. If you're the Indian health minister and you have raging infection outside, the risk is probably greater to the person coming in than to the population that's already there.
Okay, thank you. And whilst we understand the recording of cases varies globally, I have a gut feel that absolute deaths in numbers weighted against population is much lower in African countries. Do you have any comment on why that's the case?
Can you just repeat that again, Migdal?
Whilst we understand that recording of cases varies globally, I have a gut feel that absolute deaths in numbers weighted against population is much lower in African countries. Do you have a view as to why that might be the case?
I would bow to your greater experience in this matter, as my experience of the African continent is much more limited.
Not my question, it's someone else's question, but yes. Okay.
I can't, basically, I mean, the answer to that is, unless you measure, you cannot see. So if you look at what's happening in India, where was it? I think in Gujarat, the numbers of official COVID cases were a tiny fraction of the number of people being cremated. So if you're going by the official COVID data there, then yeah, okay, you've got low levels.
Perfect. Thank you. Final question. Has there been, you've talked about there being a lot of international collaboration on a lot of different areas. Is there international collaboration on the stats like you've shown today? Or are there different situations due to different vaccination rates and therefore incomparable?
So, I mean, that's an excellent question. There's a question of, one, collaboration, and two, standardization. So you want to be able to compare like with like, and it's difficult to do that on an international level where you have a great degree of variation in resources and access to testing. But there is much more collaboration. And I think there's a better understanding that unless you have accurate data of what's going on the ground, it imperils everyone. This is not just a danger to the locality. It's a danger to the whole of humanity in this case. And with regards to vaccination, that's an interesting point as well. So the story behind vaccination, and one of my main concerns really here, is the way that vaccines have been developed within the public sector using public sector resources at public sector universities, with a great deal of goodwill from people giving up their time and volunteering on the trials, and where certain individuals have been implicated in trying to prevent a public benefit to this and maintain current intellectual property rights standards. And to Joe Biden's credit, he seems to have recognized this and at least waived some of the IP requirements around this to enable better cooperation globally to enable production of vaccine at sites that are waiting to produce this, to enable it to come closer to populations that are in need of vaccine. And simultaneously, you have this tension between trying to maintain a pharmaceutical hierarchy, if you like, the equivalent of an oligarchy, of a small group of powerful and rich pharmaceutical companies with control to resource, control to legal recourse, preventing others benefiting from life-saving technologies, and a world that's desperately in need. And hopefully, the tensions that have now been exposed will enable the breakage of that oligarchy and broader access, whether it is ideally through the sharing, transfer of technology, the establishment of manufacturing capacity within the global south, a fairer means of access to logistics, freezers, etc., and the development of vaccines that are more suited to environments where we don't have the kind of advanced cold chain technology that you have in Europe. So this, I think, has energized a community of health workers, it's energized a community of activists to ask these questions. So from that point of view, there's some intellectual collaboration on that side as well.
Thank you very much for that and for your insights today. And we've gone over time. We've probably come up to Maghrib right now, so we do have to end. So thank you very, very much for your talk and for sharing us. And sorry to those who and hopefully it's a real benefit to everybody. I know that some of you might have been expecting the Islamic constitutionalism and its discontents by Hadi Inayat, but he was unable to make it today, which is why we were very fortunate also to have Umar speaking today. So thank you again. And just a reminder to everybody else about our next few talks. Next week we have Dr. Majdi Ndala, who's the Assistant Professor of Islamic Studies, who'll be speaking to us about women in the Quran, normal time next Friday. The Friday after we have a talk by Rimsar Alwane, who's a legal academic commentator at Toulouse University, talking about Islamophobia in France and is laïcité or secularism still liberal in 2021. The week after we have Sheikh Ja'far Muhibbullah, who will be speaking to us on the Wiladat of Imam Ali Rida alayhi salam. And the week after we have Dr. Joshua Ralston, who will be speaking to us about law, justice, and Sharia in Christian-Muslim dialogue following his book, as he's a specialist in the field of Christian-Muslim relations. So thank you all very much for joining today. Thank you very much for all your questions. I hope you all enjoyed the session today, and inshallah, please share the link and let others know, and look forward to seeing you next week, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.